Guten Morgen, guten Nachmittag, oder guten Abend. Not to be outdone by our predecessors, this is Ethan coming to you all with Logan, Ashley, Logan, and Addie, and we are going to talk about gastrointestinal pharmacology today. So here are the objectives for this lecture. I'll let you guys read those at your leisure. So the first topic we're going to discuss today is gastric acidity and secretion. So typically gastric acid or HCl is secreted by parietal cells in the stomach. And it does a couple things for us. It makes an optimal environment for digestion, which is a pH of about 2, for pepsin and gastric lipase to work. And then it also stimulates pancreatic bicarbonate secretion. So it really just helps us with our digestion. So a few things that can go wrong here. We can have ulcerations and hemorrhage in our stomach lining, general indigestion, dyspepsia, which is epigastric pain, and gastroesophageal reflux, which is commonly known as GERD. So we have quite a few different drug classes to treat issues with gastric acidity and secretion, including antacids, H2 receptor blockers, proton pump inhibitors, anticholinergics, metoclopramide, prostaglandins, and sulforaphate. So first, we're going to talk about antacids. Keep it simple, guys. Keep it simple, salam. Let the name work for you. They neutralize acids in the stomach. They're anti-acid. So antacids usually are a combination of a base like hydroxide or carbonate with aluminum, calcium, or magnesium. So they go into the stomach and the base combines with that HCl to neutralize it and raise the stomach pH. So here's the equation for you who are visual learners. Put the antacid in with the HCl and it gives us salt and water essentially. Indications for this would be mainly minor gastric discomfort, which is usually related to overeating or spicy foods. One bad thing about antacids is that they can kind of be abused for overeating or indulging in maybe not the best habits. So they're used as a panacea for poor eating habits. They can also be used for peptic ulcers and chronic GERD. However, due to the large amount of antacids that you would need and for such a long period of time, H2 receptor blockers and those proton pump inhibitors have pretty much replaced antacids for long-term and chronic conditions. The adverse effects include constipation and diarrhea. Makes sense because we're altering that stomach pH. There's also a phenomenon known as acid rebound, which is basically when you have increased acid secretion because you're using a base, and when you stop taking the base, you have some subsequent gastric problems. Now, this has mostly been disproven with antacids because we're not using them for long periods of time or in large amounts, but it'll come back up when we talk about those H2 receptor blockers and proton pump inhibitors. Also important to note is the changes to electrolyte absorption and the effect on drug interactions. So we are altering the digestive tract, and so we can alter the uptake and interaction of things in the stomach. So it's really important to avoid taking antacids within a couple hours of orally consuming our warfarin, digoxin, iron supplements, and some antibiotics. All right, next we're going to talk about those H2 receptor blockers. So histamine stimulates those receptors on our parietal cells in the stomach to increase acid secretion. These are differentiated as H2 receptors as opposed to H1 that exists in GI, smooth muscle, vascular, and respiratory tissues. So we kind of differentiate the stomach as H2 versus H1 in other areas of the body. So let's keep it simple again. H2 antagonists or blockers are going to bind to these receptors. And since they're not going to activate those receptors, they can't be stimulated. And so we will not have H2 mediated acid secretion. Indications for this include acute and long-term peptic ulcers, GERD, and dyspepsia. So pretty similar to our antacids. Side effects. These are typically pretty well tolerated. Most H2 receptors can be purchased over the counter. You might have headache and dizziness with these. Again, we're altering that gastrointestinal system and the internal environment. So we might have nausea, diarrhea, and constipation. Kind of a key point for us as PTs is some arthralgia and myalgia, which might be a chief complaint of our patients. So we need to pay close attention to that with our patients who are on H2 receptor blockers. And then there's, again, this proposed acid rebound phenomenon. So maybe taking these every other day has been proposed as a way to keep from developing a tolerance and prevent that. All right, now we've got the big guns. We're going to talk about proton pump inhibitors, or PPIs. So basically we have this enzyme in our stomach that secretes protons and kind of uptakes potassium into the parietal cells in our stomach. So the proton pump does that for us. So we're going to try and inhibit this pump to decrease that proton secretion into the stomach, so that those protons cannot combine with chlorine in the stomach and make HCl. Some indications for PPIs: these are the most effective treatments. So they're more effective than antacids and those H2 antagonists for control of acid secretion and ulcerations. So they are the long-term drug of choice for those gastric and duodenal ulcers, as well as GERD. It's also been proposed that there might be some antibacterial effects with PPIs, which is important for H. pylori, but nothing proven there. And then the same situation with anti-inflammatory effects. We're not really sure, but it's possible. Adverse effects of these: they're also typically well tolerated. However, this is where you are most likely to see that acid rebound phenomenon if you suddenly discontinue using PPIs after long-term use. There's also been an association between PPIs and gastric polyps with long-term use, which predispose us for gastrointestinal tumors. So it's important to keep an eye on our red flags there. Another big key point for us as PTs is the altered calcium metabolism. So we're thinking about that relationship between calcium and potassium and the inhibition of that pump. So we're going to have decreased bone mineral density, which can increase the risk for hip and vertebral fractures. So we need to pay close attention, especially with patients who are on medications that increase their risk of falls. There's also a little bit of an increased risk of some infections, possible kidney issues such as interstitial nephritis, and then we're going to have an altered absorption of some of our nutrients like iron, magnesium, and vitamin B. So it might be important to supplement with those. The bottom line: there are benefits and risks to taking PPIs, but the benefits typically outweigh those risks. So we've seen a lot of decreased morbidity with acid secretion conditions, decreased risk of esophageal damage, and cancer that's associated with GERD. These are the drug of choice for long-term treatment of acid secretion disorders. And we need to be aware of those kidney red flags and our fracture risks and know what kinds of drugs our patients are taking. All right, so last thing I'm going to talk about before I turn it over is the Helicobacter pylori infection and its relationship with gastric ulcers. So, H. pylori has been identified as a bacterium that might cause ulcers. So it makes sense that if we're treating these ulcers, we should address H. pylori as an underlying cause if it's present. But we need to keep in mind that it isn't the only factor that we need to address. And some people who have this bacteria do not have gastric ulcers. So by eliminating this underlying cause, we can often reduce the need for other interventions, which can save us a lot of medical expenses and time. So how are we going to treat this? Good old drug cocktail. So we're going to use some combination therapy here. Typically it combines a pair of antibacterials with a proton pump inhibitor. So a common example would be amoxicillin, clarithromycin, and omeprazole. Combination can also include a bismuth compound, which we'll talk about a little bit more when we get into the antidiarrheal section. Just like other antibacterials, we're going to administer these medications usually 10 to 14 days. However, we might use those PPIs for a little bit longer to kind of facilitate some healing of the ulcers and prevent the ulcers from recurring. Now I'm going to turn it over.
Hey guys, it's Addie. I'm going to continue talking about drugs that are going to be used for gastric acidity and secretions. First one is going to be anticholinergics. We've talked about anticholinergics quite a bit in this course, so a lot of the information is going to be familiar, but I understand we forget kind of what goes on sometimes, so I'm going to start with just a little reminder. Acetylcholine, it's a neurotransmitter that's used in our parasympathetic nervous system. and the parasympathetic nervous system is what is resting and digesting. And so it kind of seems backwards because digestion is a very mobile process. We've learned that it moves food from our stomach to our small and large intestines. And usually I think of mobility with the sympathetic nervous system. But if you're running from a bear and you just ate a hamburger, you don't want the blood going to your stomach to help digest it. You'd rather that blood be going to your muscles, your heart, your lungs. And so it makes sense that you're digesting when you're resting, and that's during parasympathetic nervous system innervation. So we've kind of learned more about digestion from the other lectures so far, but just to review, during digestion, there's an increase in gastric acid secretions and motility. And like I said, it's innervated by the vagus nerve. And so anticholinergics just overall are going to inhibit the action of acetylcholine. This little diagram I kind of took from one of Jim's previous lectures, but I've overlaid the stomach instead of the heart, which is where we originally talked about it. So as we can see, the presynaptic and postsynaptic neurons both release acetylcholine, but the postsynaptic neuron is going to release the acetylcholine onto the effector organ, which in our case is going to be the parietal cells in the stomach. So overall, the mechanism of action for anticholinergics is to block the effect of acetylcholine on the parietal cells in the stomach. By blocking the effect of acetylcholine, we're going to inhibit the parietal cell action, which is going to decrease the release of gastric acid into the stomach. In addition, anticholinergics are going to relax muscles and reduce motility. There's a few drug names right below that you don't really need to know, but atropine is just one that I've seen around. It's a very common anticholinergic. And a fun fact that I found was atropine can also be used to dilate your pupil during an eye exam. And during our home health visit, Bill told us that some eye drops can also be used when ingested to induce vomiting and diarrhea. So if you ever need to do that, guess you can use eye drops. So some indications of anticholinergics include ulcers, GERD, intestinal spasms, IBS, and colitis. And then the adverse effects kind of make sense if we think about anticholinergics inhibiting the parasympathetic system. The adverse effects are going to be sympathetic responses. So again, sympathetic, you're going to have decreased secretions, you're going to have increased heart rate, anything that's going to help you go into that flight or fright motion. So specific adverse effects include dry mouth and dry eyes, constipation and urinary retention, which again, whenever your sympathetic nervous system's on, you're not going to be thinking about moving food or going to the bathroom. So those things are just kind of going to shut down. Tachycardia and confusion. This photo specifically talks about atropine because it's just one of the more common ones, but it's also relevant for adverse effects for other anticholinergics. And so hot as a hare, you're going to get warm. Mad as a hatter, you can have some confusion. Red as a beet, you're going to become flushed due to the increase of blood. And then tachycardia, increased heart rate, and dry as a bone, decreased secretion. So this is going to be in the GI system as well as the mouth and the eyes. An important thing to note with anticholinergics is you do not want to use them with intestinal obstruction. If you think about it, if you have an obstruction in your intestinal system and you're introducing something that's going to further slow down mobility, just not going to be a good outcome. So that's just a contraindication for this type of drug class. So moving on, we're going to talk about metoclopramide. This is a dopamine receptor antagonist. So at its very roots, dopamine is going to inhibit gut motility and stimulate acidic secretions. And so if we're using a dopamine receptor antagonist, we're going to have increased gut motility and decreased acidic secretions, which kind of sounds a little backwards because I just explained that anticholinergics are going to help slow down your GI system. And this is stimulating your GI system, but it'll make sense here in a moment. So the mechanism of action for metoclopramide is to stimulate the motility in the upper GI tract to help move your stomach contents down to your small intestine. And so we're focusing on moving things more quickly through the tract to decrease the risk of acid going back up the esophagus. So just with that mechanism of action, it would make sense that this drug is going to be indicated for children and neonates with GERD. We want to move things quicker, and so there's a decreased risk of acid. This drug can also be used in those with diabetes who have gastroparesis. So if you have semi-paralysis of your GI system, you're going to want a drug that's going to stimulate gut motility to help things move along. And then the last one, which is pretty interesting, it can be used to prevent nausea and vomiting in those undergoing chemo. And this kind of makes sense because if you're moving things from your stomach to your small intestine quicker, it's going to decrease the likeliness that it's going to come back up from your stomach as vomit. So some adverse effects for metoclopramide include restlessness, drowsiness, and fatigue, and then Parkinson-like tremor and rigidity. So like I said, this drug is a dopamine receptor antagonist. So we're preventing the binding of dopamine to different receptors. And if we think about Parkinson's disease, that is the reduction of dopamine producing neurons. And so it's kind of going to make sense when we have a decrease of dopamine binding that you're going to get some of those Parkinson-like symptoms, so tremor and rigidity due to those effects. Moving on, we have prostaglandins. This is another drug class that we've talked about quite a bit in this class. So, but again, reminders, I know we forget things sometimes. Prostaglandins inhibit gastric secretion and they stimulate the stomach mucosa to protect the stomach lining. Mechanism of action, not really completely known. And that kind of goes hand in hand with the indication, not entirely understood. We're not really sure if there's any advantage over other anti-ulcer drugs as using exogenous prostaglandin analogs to treat peptic ulcers. But they do know that if you have damage to your stomach lining by aspirin or any other NSAIDs, that the treatment of this gastric damage should be done by prostaglandins. So specifically, the prostaglandin drug name would be misoprostol. And this is definitely something as a PT we need to understand because a lot of patients are coming to us with pain. And what do you do when you're painful? You take aspirin, you take NSAIDs. And as we've learned, an overuse of that can lead to gastric damage. And so you want to be sure that you understand that treating with prostaglandin, specifically misoprostol, is going to be used for that specific type of gastric damage. But like I said, no other advantages over anti-ulcer drugs. And I've kind of also found out that this drug might only be effective at doses that cause adverse effects. And so it has to be such a high toxic dose to be effective that we're getting adverse side effects. So adverse side effects for prostaglandins include diarrhea, intestinal cramping, and menstrual irregularities. And we have another contraindication with this drug class, that being pregnancy. Taking prostaglandins while being pregnant can induce abortion. However, if you are at full term and needing to induce labor, prostaglandins can also be used to induce labor. The last one we're going to talk about is sulcrafate, and this is probably my favorite one. I know there's been a lot in this section of pharmacology, but sulcrafate is my favorite and kind of the cutest one if I had to pick one. But its function is basically to stimulate ulcer healing. So it works by stimulating prostaglandin synthesis in the mucosal cells, which we already know prostaglandins are protective to the stomach lining. So again, makes sense. But it's a gel-like substance that's going to adhere to the ulcer. So in the photo, you can see the green outline, that's sulcrafate, and that is just protecting that ulcer, that ingrowth. So I kind of think about it as like if you have a scrape, a blister, a cut on your skin, you're going to put a Band-Aid over it to protect it from bacteria and other further damage. So sulcrafate to me is like an internal Band-Aid. You're putting sulcrafate over this ulcer to inhibit pepsin from being able to digest the mucosal proteins and help it grow without getting further impacted by the outside acid and enzymes. So its indication is just ulcers. Adverse effects for sulcrafate include constipation, flatulence, and decreased absorption of some drugs. So by no means do you need to remember any of these drugs, but digoxin is used for heart failure and antiarrhythmic. Phenytoin is an anticonvulsant, and we just learned that tetracyclines and fluoroquinolones are both antibiotics. And so it's just going to decrease the absorption and effect of those drugs. However, overall, sulcrafate is typically well tolerated by patients. So closing in on this gastric acidity and secretion portion of the pharmacology, we have some PT implications for the whole section. It's important to note that many patients are going to be on drugs that impact the GI system. As we've learned so far from other lectures, there are many things that can go wrong in the GI system, and a lot of them are pretty common. So it won't be uncommon to see a patient in your clinic, no matter what setting you're in, have a GI system-related drug. In addition, stress ulceration syndrome is prevalent in the ICU in patients with burns, multiple traumas, renal failure, and CNS trauma. And although we didn't specifically cover stress ulceration syndrome, we did talk about ulcers. And so maybe in these types of settings, you're going to experience patients who are going to be more inclined to be on drugs that specifically are indicated for ulcers. Next, moving forward, we want to just be aware of side effects. That's kind of like with any drug, but mostly in this class, any side effect that's going to leave your patient with an impacted energy level or mental state and their bowel and bladder habits. So asking in your subjective about their bowel and bladder habits, and then further investigating about what they look like. It can be kind of uncomfortable, but it's important when they're on drugs that are going to be impacting that. And then lastly, just making sure we're doing a good job with differential diagnoses. As I mentioned, metoclopramide can kind of leave those Parkinson-like signs and symptoms. So you want to make sure if you see your patient come in being rigid and having tremors, that you're kind of diving deeper and trying to see if it's actually a Parkinson's disease or if it's just an adverse effect from their GI medication. And this can look like asking subjective questions, the onset, and diving in further with the medical history. And that is it for gastric acidity and secretion. I'm going to now turn it over to Girl Logan, who is covering antidiarrheals.
All right, guys. Girl Logan here. I am so excited to talk about antidiarrheals with you. So first, to understand antidiarrheals, we need to understand why diarrhea occurs in the first place. So if transient time through the GI tract is too fast, it's going to result in poor food absorption and dehydration. So this is a temporary symptom of many GI disorders. So let's do a little bit of review here. Crohn's disease is a chronic inflammatory bowel disease. It affects the lining of the digestive tract. This causes abdominal pain, weight loss, anemia, and fatigue. And then a big one is diarrhea. So this picture here shows that it is affected in the small intestine and large, and it's kind of spotty through there. And then going to ulcerative colitis, this is also an inflammatory bowel disease, which abnormal reactions of the immune system cause inflammation and ulcers on the inner lining of large intestine. So you can see there on the right side of the picture, the small intestine is not really impacted, but the large intestine, including the rectum, is highly, highly impacted. So one antidiarrheal that we're going to talk about here is bismuth salicylate. This stimulates water and electrolyte absorption from lower GI tract, which is decreasing the fecal fluid loss. It does have antibacterial effects, which can inhibit production of prostaglandins that irritate intestinal lining. It also decreases gastric acid secretion and exerts antacid effects. So what would this be useful for? The answer is that it'll help stomach upset and minor gastric irritation. It is an active ingredient in Pepto-Bismol. I feel like that is a pretty common drug that is readily available over the counter commercial product that most of you will recognize. It's relatively free from serious adverse effects unless it's abused or those who have sensitivities to salicylates. So another area that we're going to focus on is opioid derivatives. These produce generally decrease in the GI motility. They reduce fluid loss by increasing absorption of salt and water, or by decreasing fluid and electrolyte excretion. A huge mechanism that these drugs focus on is anti-peristalsis, which in order to understand that, we first need to understand peristalsis. So looking over here to this black and white picture, this is the normal process of peristalsis, which is a downward wave-like movement of smooth muscles in the GI tract. So the little circle is food being pushed down by the smooth muscle down out through the large intestine. So anti-peristalsis, let it be easy for you, it will be opposite. It describes contractions of the intestine that force the contents in the opposite direction to normal. It reduces the movement of feces through the intestines. So the pink picture there is describing it going in an upward motion rather than the downward one. These opioids bind to neuronal receptors within the gut wall, or they do have that direct effect of GI smooth muscle. Here are some opioid derivatives listed here. Not necessarily for your memorization, just recognize them. And some adverse effects that can come with these type of drugs is nausea, abdominal discomfort, constipation, which, as Jim would say, let this be easy for you, anti-diarrheal drugs stop diarrhea and can lead to constipation. Makes a lot of sense, I would say. Not as often symptoms we have are drowsiness, fatigue, and dizziness. All right, so wrapping up antidiarrheals, there are some other drug strategies that can be used here. So just for specific cases, clonidine usually is used to treat hypertension, but it can be used to stimulate alpha-2 receptors, thus decreasing secretion, increasing absorption, and normalizing GI movement. Octreotide is specifically useful when treating diarrhea that is caused by tumors in the body. And then finally, we have bile sequestering agents. These are useful in treating diarrhea caused by excess bile and acid secretion. Again, I'm not overly concerned about remembering these drug classes. I just want you to understand that other drug classes can be used as antidiarrheals for specific cases. So now I'm going to turn it over to Ashley.
All right, thanks, Girl Logan. So now that we went over antidiarrheals, we're going to talk about the exact opposite, laxatives. So a laxative is something that you use. I feel like we all know what that is technically. It helps clear out the system. So it promotes defecation when there's no obstruction present in the GI tract. A cartharytic is another type, except for it just promotes it more quickly. That's the biggest difference between laxative and cartharytics. Some pharmacological uses for laxatives would be prolonged bed rest, painful bowel movements, spinal cord injuries, depending on where the lesion is, patients who should avoid straining to defecate. So if we've just come off of surgery and we're not wanting to open up that scar that was just, or that wound that was just created, this could be a good tool used. We could also use it to clear the bowel before or after surgery or a diagnostic procedure. A big thing that we have talked about is opioids, how they can induce constipation. A laxative could be prescribed to help relieve this as a side effect of the opioid. So some pharmacological abuses would be if somebody relied too heavily on a laxative. So they're not being able, their system is no longer able to push out the fecal matter, and they are constantly using this laxative to do it for them. So weight loss is another pharmacological abuse. People taking laxatives are doing this so they can clear out their system more, so they can hit a specific weight. Populations could include eating disorder patients or athletes trying to hit a specific weight, possibly a wrestler, to get into their specific class. So mechanism of action, there are 4 different laxative types that we're going to talk about. These are the first 2. The first is the bulk forming laxative. This one is designed to absorb water and swell up the GI tract to help stimulate the peristalsis. So exactly opposite of what the antidiarrheals wanted. They're wanting to soak in some water, so it makes it a little looser to come out. These are some examples of the drug names, but an over-the-counter drug that you guys most likely have seen is Metamucil. Another laxative type is a stimulant laxative. Let the name work for you, it stimulates some GI motility. The specific mechanism of action isn't fully known, but it's supposed to just activate the peristalsis, so get everything moving so we can get defecate a little easier. It may also be stimulating the nerve plexus and the gut wall, also just moving things along better. And an over-the-counter drug for this is Dulcelex. So last 2, a hyperosmotic laxative. Same thing, let the name work for you. It pulls water into the bowel so it can produce the bowel to increase in size, stimulating peristalsis. The last 3 laxatives have been very similar. They're trying to make the intestines grow, so then the peristalsis will kick in and move everything down. I'm sure everybody knows this one, but Miralax is the over-the-counter drug for this. And lastly, we have lubricants and stool softeners. This helps facilitate entry into the fecal mass itself. So not even just the bowels, but into the whole mass of substance. It softens the stool, permitting easier defecation. So as everything loosens up, it's easier to come out. A over-the-counter drug for this is Kool-Ace. So some adverse effects for laxatives is excessive loss of fluids. So especially with the stool softeners, if everything's coming in and getting really liquid, it might fall out a little too easily. So you could be losing some electrolytes and just fluid in general. And a chronic use is another adverse effect, just because it causes that dependency to where your body can no longer perform the actions that's needed to be able to defecate by yourselves. And chronic use could also result in some serious lower GI irritation. I just want to let you guys know, laxatives, some PT implications, kind of like what we talked about during the pool or the aquatics therapy. If your patient's on laxatives, it might be easier for them to defecate. So maybe we don't want to put them in a pool and make a mess, or being cognizant of that if they're on these medications, that things could be loosening up. But we also want to educate our patients on that physical activity can help with this. If they're moving around, even just walking can help loosen up our GI motility and help defecate. So now I'm going to pass it over to Boy Logan to round us out.
Thanks, Ashley. Hey guys, it is Boy Logan, and what we're going to be talking about is digestants. And we're going to make this the repeating process of let's make this easy for you guys. The purpose of these are to aid in the digestion of food. I'll let you guys sit on that for a second because that's a heavy concept. And I'll say it one more time, aid in the digestion of food. The primary digestion preparation can contain our pancreatic enzymes, so trypsin, lipase. These are responsible for digestion of carbohydrates, proteins, and lipids. These are normally synthesized in the pancreas and released via the common bile duct. Another thing that we have are the bile salts, and these emulsify lipids into the intestinal tract. It's important to know that it's in lipid digestion and absorption, and they normally synthesized in the liver, are stored in the gallbladder, and released via the common bile duct as well. So why is this important, and why is this important to us? So the importance of digestions can replace digestive constituents in the stomach and upper small intestines if endogenous reproduction is impaired. So cystic fibrosis, this is something that we've talked about in class multiple times now, and it's a hereditary disease that affects all major exocrine glands. They lead to the chronic deficiency of pancreatic enzymes and bile salts. Patients cannot normally absorb nutrients from the GI tract. So the important thing about this is that I want you guys to look at digestants and look at cystic fibrosis. Like, this is an important concept for us to know. And the reason why these patients need digestants is that they can't do this on their own. They cannot digest the missing compounds that they have, and they need to improve digestion and nutrient absorption. So one more time, I'm going to repeat myself again because I believe this is an important concept, is that the role of digestants for cystic fibrosis is to replace the missing compounds and improve digestion and nutrient absorption. So I don't know if you guys should put a star on that or anything like that, but that would be important to know. So emetics, these are not my common theme that I would like to talk about, but we have to talk about it, and they induce vomiting. So they are frequently administered to help empty the stomach of poisons or ingested toxins. There are two primary emetics, and it's apomorphine and ipecac. Those are two, and I wouldn't necessarily remember those two specific, just know that there are two emetics, and both agents work to stimulate medullary emetic centers. Ipecac has a different effect on the stomach. I know a lot of people don't like vomiting, but I felt like give you guys a little visual concept of my little friend, Mr. Emoji, and he's getting nausea and then he's vomiting. So this is what emetics are doing. They are inducing vomiting. The next thing we're going to go off of is antiemetics. So the complete opposite of emetics. So emetics induce vomiting. Antiemetics
We want to decrease nausea and vomiting. And these are associated with motion sickness, recovery from surgery, other medical treatments, chemotherapy, and radiation treatment. So one more time, just to make it clear for you guys, emetics, we're inducing vomiting. We want people to vomit because they cannot get that stuff out, whether it's bad or anything like that. Antiemetics, we do not want nausea and we do not want vomiting. So antiemetic agents, these might look a little familiar from all my friends talking about these. Antihistamines, anticholinergics, drugs that block the CNS, dopamine, and serotonin receptors, and then other drugs in the CNS to suppress nausea and vomiting. I hope all that makes sense after talking about all this stuff today. Antacids and adsorbents act locally to soothe the gastric mucosa and decrease irritation and may cause vomiting. So they're decreasing the irritation that may cause vomiting, just making that make sense. So the first bromance we have in the corner right here is Polly and Jim, and they approve of antiemetics. This might sound like a lame little story, but Jim told me, and this is how I remember antiemetics compared to emetics. Him and Polly were watching the Final Four together this year, and that after Duke sadly lost, and it was Coach K's last game, Polly got a little too intoxicated, and Jim was really scared that Polly might have to pull the trigger and may need to puke. So after that was happening, he went into his pharmacology mind, and he was just like, what's the last thing that we don't want him to do? Is we don't want him to have nausea and we don't want him to have vomiting. So Jim handed my boy Polly antiemetics, and that led to Polly not vomiting. So I don't know if that's going to work for you guys. That's a little clue in my head, just remembering that Final Four loss, Coach K's last game, and that Jim, being the bro that he is to Polly, led to him not vomiting or puking. So if that's a bad joke or if that's a bad story, you guys can tell me that in class later, but that's just my way of remembering antiemetics and emetics. And so these are our references. If you have any questions for us, please let us know. And I hope you guys have a great rest of your day.